Hello, everyone. Thank you for being here today to the workshop. As an Itch is Kinetic, we like to present what's new with our products. All right, we're focusing again on sport base. All right. This is a series of workshops, okay, that we have bring to the program since 2018. And today I have great honor to be here with Dr. Krebs and Dr. Carvalho, who's going to share the clinical, okay, evidence and practice with the sport base in soft tissue injuries. Pretty important. I'm Diego Guillen from MDT International. We're based in Geneva, a medical device company. This is to give you an idea of the organization overview, very well spread, okay? We are a company that has a know-how in HA technology, everything that we do. We have a patented technology and products based on HA. Under our R&D portfolio, let's say, we have HA, we have a patented HA platform, right? That serves like a carrier to active molecules, all right? Pretty important for oncology, Alzheimer's, IBD, all right? And this is what we bring into the market, innovative patented devices. This is the coverage the MDT has, all right, to date in the world with our products. And just to give you a snapshot of what is going on right now, okay, what's going to be happening, we're going to be speaking about functional and radiological effects of STAVA, all right, in the management of tendon and ligament injuries, all right. We're going to start with Dr. Fabio Krebs. At the same time, just for you to know, we are recording this presentation, this workshop. We have an online Zoom link. We have 50+ participants already registered. Please, for the Zoom audience, type your questions. There's going to be, as you see down the bottom of the agenda for today of the workshop, some Q&As, and we'll be able to address them. Of course, there's a lot of people, so we're just going to try to select the most appropriate ones. All right. With no further ado, I would like to invite here Dr. Krebs, okay, to start his part of his presentation. Please, Dr. Krebs.
Hi, it's a pleasure for me to stay here and talk with you some about my experience with using personal experience using STAVA, and I would like to talk about functional and radiological effect of STAVA soft tissues adapted biocompatible hyaluronic acid in the management of tendon and ligament injuries. My clinical experience. There is a conflict of interest in this presentation. Nowadays I'm a president of a Brazilian Society of Orthopedic Traumatology in regional Rio Grande do Sul in Brazil. I'm a doctor of CONMEBOL, a South American Confederation of Soccer, and I have a lot of experience in treatment of the patients that practice sports. And of course, in my office, patients that not athletes of elite. Well, one is STAVA, soft tissues adapted biocompatible hyaluronic acid. Personal experience more than 6 years with excellent results. In Brazil, SportVias is a viscous supplement for soft tissues approved by National Health Service Agency as a result of clinical studies with the product. What's the benefits in soft tissues injuries, ligaments and tendon? Soft tissues, STAVA, soft tissues adapted because of his high biocompatibility. High biocompatibility is a result of its purity profile. Purity profile is achieved with an exclusive patented manufacturing process. How does STAVA work in a ligament injuries? especially in ankle sprain. In acute phase, 48 till 20 hours, occur inflammation and bleeding is present. When injury occurred, fibrin blood component is present and in body increase hyaluronic acid production. Injection from a gel-like complex STABA plus fibrin into the injury site that provide larger hydrodynamic volume in situ as a cushion for physical support scaffold effect. We provide support internally, increase cell proliferation and reduce the inflammation. Is a innovate treatment to relieve the pain and optimize the recovery of tendon and ligament injuries. A product used for acute and chronic soft tissues injuries. What's the results? Better realign, qualify, less scar tissue formation, provides lubrication, hydrodynamic volume to reduce adhesion, and allows better structural configuration of fibers, faster reconstruction and recovery. I have used in some pathologies like a medial and lateral elbow epicondylitis, ankle sprain with ligament injuries, rotator cuff tendinopathies, and sometimes off-label has shown a lot of effectiveness and tissue recovery. For example, patellar tendinopathies or ruptures, partial ruptures of Achilles tendon, plantar fasciopathy, plantar fasciitis. In my clinical experience and personal experience, ankle sprain with ligament injuries, shoulder tendinopathies, infrapatellar tendinopathies, Achilles tendinopathies, partial rupture of the Achilles tendon, medial and lateral elbow epicondylitis, and plantar fasciitis. My results, my experience has shown efficiency in acute and chronic injuries, in ligament injuries, tendinopathies, epicondylitis, plantar fasciitis. In acute injuries, it immediately assists the recovery and regeneration in injured tissues, ligaments, and tendons. In rotator cuff, I see the important aid and lubricating affected region and thereby also help improve vascularization and increase potential for regeneration with better realignment. Dr. Carvalho will talk about this more specifically. Patients report excellent results. In the shoulder and ankle, the feeling of cooling in the infiltrated segment occurs shortly after the filtration. In the elbow, as a structure with less space for expansion of the disc supplement, painful discomfort may occur in the first 24 hours. I perform this treatment in acute ankle sprain with injuries, with ligament injuries, which have provided a very adequate anatomical realignment recovered with practically no injury recurrence. That is important information for us. Another information that is so important for doctors that treat athletes of elite and have a competitions officials. STABA is not considered doping and can be applied to professional patients, professional athletes. This is important for us in our office. Some information about the injection technique. I have to use aseptic method, a good aseptic method, gauge with alcoholic chlorhexidine, anterolateral, medial, medial. The needle used. I use the needle 21 gauge is indicated 21 to 27. I have used 21 gauge with 1.5 inch. The infiltration in the shoulder, you can do guided by ultrasound in rotator cuff tears from proximal to distal and vice versa. Usually supraspinatus and subscapularis. We are demonstrating this video the same. When you talk about elbow, place the needle at 45 angle in relation to the point of maximum pain. After puncture, put the needle at the angle parallel to the skin and infiltrate the point of maximum pain in the side of medial to lateral or lateral epicondyle. Inject half of the content of the syringe while the needle is removed. When you remove the syringe, you inject the viscous supplement. Return without removing it completely. Rotate the needle 108 degrees for the opposite direction and insert the same. inject remaining content while needle is removed. Here demonstrate infiltration guided or not, it's optional in conduits from proximal to distal and vice versa. Usually wrist extensors and wrist flexors. In the ankle, a periarticular infiltration during one penetration at the level of the anterior talofibular ligament, that the principal ligament compromised that have a rupture or partial rupture in the ankle sprain. We believe that 85% of the ankle sprain occur a damage of this ligament. The second filtration must be performed between 2 to 7 days from the first filtration. We can use ultrasound guided in the ankle spray, as demonstrated in the picture. When you do the infiltration of a staba in a ligament and anterior talofibular ligament, that's the principal, and calcaneal ligament with the demonstration in this video. When you have a component more posterior or medial, you have to do the same position, the proximal to distal when you remove the needle. After application, Band-Aid with micropore tape is necessary just to protect. Preference, MRI or ultrasound before the infiltration, radiology examinations required by local authorities, images request prior to the treatment, follow-up, observe the realign process, the shoulder and elbow 4 to 6 weeks later, and ankle 6 to 8 weeks later. Some observations. What are the realign times return to normal function? Rotator cuff average 30 to 40 days. Epicondyles 45 to 60. Ankle sprain 30 to 45. Is beneficial to apply earlier, suitable for acute ankle injuries. I have used it in more chronic situations like tendinopathies in the shoulder and elbow, because the patient seeks medical assistance when he had pain for some time. Any benefit using SportViz to accelerate realigning post-operative? I have no use it routinely, but I see the possibility of assistance if the realign process of label in surgical procedure for tendon repair, when it could benefit it completely tendon tear, stop application after suture. Importance of imaging. I consider that the radiological image performed before and after the infiltration of staba can show the recovery of the tissue regeneration of the affected segments, being an important data to verify the effectiveness of the therapy. Contraindication to use. Some patients that have some dermatosis in the infiltration area to avoid possible complications of infection secondary. I will show you some cases, documented case showing preview and posterior radiological image with SportViz application and the tissue recovery. This is a man, 35 years old, that have an ankle sprain, and MRI show with anterior talofibular and calcaneal fibular rupture that you look here. After application, we did a ultrasound that moves thickness and anterior talofibular and calcaneal fibular ligaments without ruptures, and after realize another MRI when ligaments lesion recover and realign, that you can see the new ligament, the recovery of the ligament. When you compare before and after, you have the sign, the radiological sign of the ligament recovery. And when you look the range of motion, the aspect of the ankle, before and after, before, after, before and after. Another case, a man 25 years old with a ankle sprain, and the MRI showing partial tear of anterior talofibular ligament and deltoid ligament strain. After application, you can see the recovery of the ligaments that was compromised. Look here, the image showing. When you compare before and after, before and after, you have showing the recuperation. Here we can see the range of motion and the aspect before, after, and the same. Another case, a female, 40 years old, left ankle sprain with a rupture of anterior fibular and fibrocalcaneal ligaments. The MRI showed the lesion. After application, you can see the new ligament, the recovered ligament, showing at the MRI. When you compare before and after, before and after. Another female, 36 years old, with a right ankle rupture of anterior fibular and fibrocalcaneal ligaments. And after application, you can see the ligament recovered and now image in the MRI. Comparing before, after, before, after. The sign of the MRI showed the regeneration and recovered ligament. Another case, a man with ankle sprain with anterior fibular ligament ruptures, and after recovered the ligament. You can see recuperation of the ligament, the recovered, with an image showing this lesion. When you compare before, absence the ligament, here you can see the same. Another option to use in Achilles tendon partial rupture, a man that was doing a running and a futsal game with a possibility to full ankle flexion, palpable gap in the path of the Achilles tendon. MRI showing partial rupture approximately 90%. You can look after lesion, before lesion, and after. Almost complete rupture, and here the tendon regenerated. And here you can do a flexion plantar of the ankle after the application. This is another patient with a partial rupture of the Achilles tendon, showing the impossibility of the full flex the ankle, significant edema, and MRI rupture about approximately 50%. You can look the lesion in the side, the truth, of course, and after absence of lesion, totally recover, and you compare here and here, here and here, totally recover tendon. And of course, the range of motion recuperated. Football Club Barcelona have a protocol. Dr. Javier is here. Thank you for staying here in our presentation. With clinical and neurological diagnosis with ultrasound, grade 2 ankle sprain, infiltration guided by ultrasound. In the hospital that I work, we standard protocol traumatology service, shoulder, elbow, ankle, and foot pathology with excellent results. I will show one video that explains step by step how can I do a.
Olá, eu sou Jorge Krebs, ortopedista. Vou demonstrar para vocês a técnica de aplicação dos suplementos.
How can I do ankle infiltration?
O paciente está apresentando uma sequela de torce tornozelo recente.
Ankle sprain with anterolateral ligament.
Pegando principalmente o ligamento taufibular anterior, que é o que na maior parte das vezes dos torce tornozelos está comprometido. Vou mostrar para vocês passo a passo agora do procedimento. Primeira coisa, deixar o paciente no posicionamento em decúbito dorsal. E vou pedir para que ele tente ficar relaxado antes de começar a fazer todo o procedimento. Fundamental algumas medidas de.
In this case, I don't use ultrasound
Eventualmente que ocorram.
because the ligaments are so peripheral.
É importante
You
a gente ter uma
can
noção
use.
da sintopia dos ligamentos. Quando a gente começa a fazer o teste e questionar o paciente, esse ponto, vamos lá, é o ponto onde a gente vai localizar o ligamento clavicular anterior, que é o mais comumente.
How can I said
Então, a gente traça
before, proximal to this.
eventualmente, esse complexo lateral que compõe o ligamento fibrocalcaniano também pode estar comprometido, mas não é o caso do nosso paciente. Passo seguinte, a gente começa a
sepsis
fazer
that you
mais
have
cuidados
to do.
relacionados à higienização. É importante que a gente utilize algum tipo de antisséptico. No caso, eu tenho curado utilizar a clorexidina alcoólica.
Alcoholic chlorhexidine that I use.
Todo complexo, mesmo que saia um pouco da marca, da aplicação, toda essa região. Tomando sempre cuidado para, eventualmente, a passagem de algum gel. Posteriormente, a gente vai pegar. Eu, particularmente, gosto de utilizar na infiltração uma agulha, né, do calibre 0,80
The good that I was talking
considerada de
before.
21,2, que é a agulha recomendada para se fazer a infiltração. No momento que a gente estabelece o ponto de dor, vamos lá? Mais interessante. A gente vai fazer uma angulação aproximada de 45 graus, direto ao ponto de origem do ligamento. No momento que a gente chega no ponto de origem do ligamento, a ideia de aplicação do viscosuplemento do esportivista é começar a aplicar no momento que vai recuando a agulha.
When you are retiring, you put
Estou recuando a agulha, estou retirando ela. Chegou até essa parte, volto mais um pouco, aplico novamente no momento que eu vou retirando para pegar o trajeto do ligamento e sem fazer a ressecção, a retirada da agulha, eu giro em cima dele mesmo, mesma infiltração,
without removing the needle. You can
faço 2 sentidos até que a gente consiga a aplicabilidade do viscosuplemento em todo o trajeto do ligamento lesionado. Retirado, faz um pouquinho de compressão. O curativo, basicamente, é feito com a aplicação que haja manutenção da estrutura onde foi feita a infiltração.
the micropore 8.
Você aplica uma camada de micropore, normalmente a segunda. Está feito a infiltração.
Final considerations. Very useful to help realign and recovery of injured tissues with improved biological pattern, more anatomic cell signs, less rigidity, less adhesions, mechanic effect, improvement of connective tissues, lubricant effect. Some considerations: biocomfortable, make the appropriate choice of the patient to be submitted to treatment, explain how to infiltration will be made, perform good cleaning hygiene. Indicate for acute and chronic case in amateur, professional, and non-sports athletes patients. Avoid sports practice as well as longer deambulation after infiltrations. Sportivist is a therapeutic modality that helps in tissue recovery and regeneration, promoting better and more adequate realignment. Is able to help reduce pain experience from soft tissues injuries. It's very important method that assists the recovery improvement of the functional and significant decrease in recurrence of injuries. STABA allows to have early return to mobility. It's very important to do a good infiltration technique. Doing ultrasound guidance is better, is easier. We watched yesterday the ankle sprain that occurred with one of the best tennis player in Roland Garros. Zverev in a semi-final of Roland Garros suffered ankle sprains. We believe that is a good option for treatment for your ankle use of STABA. If I was a doctor from him, I would like to use. There are a lot of international clinical evidence since 1907 with including ankle, elbow, shoulder, other in this Congress, I had a poster that was about the report cases in treatment of ankle sprain with infiltration, with soft tissues, with biocompatible hyaluronic acid. Thanks so much for staying here, and I pass to Dr. Carvalho that continue our presentation. Thank you.
Good afternoon. My name is Luís Carvalho. I'm a physical medicine and rehabilitation specialist and specialized in sports medicine and pain medicine in Portugal. I am the chief of the department of the musculoskeletal intervention and rehabilitation unit at Centro de Reabilitação do Norte in Oporto. Okay. Kindly wanted to thank the MDT for this invitation. I am going to try to follow this excellent presentation by Dr. Krebs about this tendon compatible hyaluronic acid. Okay. Stava. So the purpose of this presentation is to talk a little bit about ultrasound guided injection of this medical device in the rotator cuff tear. Okay, and then we can talk a little bit about some indications or about injection technique and evidence of healing. Okay, so this is my conflict of interest. Before jumping into this more specific subject, I'd like to talk a little bit about what is the problem around this rotator cuff tears. It's a very prevalent pathology, very prevalent on trauma or on degenerative status, and we need to know a little bit more about, be more specific about this kind of injury, because this is an awesome solution. It's a very, very good solution. In our experience is bringing this to the game, but it's not the solution for everything. Okay, we need to be more specific when approaching this kind of pathology. And inside the rotator cuff tears, we have tears that are complete, they are partial, they are focal, they are articular, they are intersubstance, they are partial, they have retraction, less retraction. So we need to dominate all these kind of features about this injury to choose the better treatment management option to our patient. Okay. Ultrasounds, in our consultation, we cannot have MRIs every day, okay, and it's not that accessible. But we can have ultrasound devices. I have an ultrasound device in every room of my consultation on our unit in the hospital, and we can do a very good correlation between what we see, what we ask to the patient, what we understand on the physical exam, and then we suppose to have some kind of lesion, and we can put an image on that injury that we were thinking about, and we need to know, we have to have a tridimensional image of this kind of tear to choose the better option for our patient. So we need to know if this tear is complete or it's partial, and you can see this on the transverse view. Okay, and this is the long portion of biceps brachii, and here also the long portion of biceps brachii. This is supraspinatus. This is the common fibers, and this here is the infraspinatus. Okay, and if I have on the anteroposterior view, if I have a rupture like you see here, this hypoechoic line, okay, from anterior to posterior, then this is maybe a complete tendon, a complete tear, because it catches all the anterior to posterior fibers, okay, that attach to the bone. So it's a complete tear. And it's more severe than a partial tendon tear, because as you can see here, if this is my LPB, okay, these are my most posterior fibers of the supraspinatus on the transition to the more anterior fibers of the infraspinatus, and I have here a small tear. So this is a complete and this is a partial tear. Okay, they are both candidates to hyaluronic acid, but if we are talking more than the anteroposterior insertion, what about the thickness of the tendon? And this is where things get a little bit more tricky or more complicated, because I can have a tear that goes from the articular side. Okay, this is the humeral head. This is the acromion, from the articular side to the bursal side, and I have here a communication. okay? It's a full thickness tear. Or I don't have this communication, I only have a tear on the bursal side, or in the articular side, or maybe intersubstance, okay? And interstitial delaminative. This is important. This is an awesome classification by Dr. Ellman. He calls on the focal, on the articular side is a type A, intersubstance is a type C, and the bursal side is a type B, just like the first letter. This is important because when I have this kind of tear, if I have a young man and he's doing heavy loads, has a professional activity that implies overhead activity, this is a traumatic tear. He falls down, he was pushing a heavy object, and he comes to my consultation, and I'm not a surgeon. I'm specialized in minimally invasive procedures, but I'm not a surgeon. Maybe this guy has no fatty atrophy on the muscle belly. Maybe this guy is a good candidate to surgery. Okay, we need to know that. We need to be honest with our patients, because we cannot only think about our patients right now, because some colleagues tell me, okay, but this guy, he has almost full range of motion, active, and you can take his pain away. I know you can, so why don't you take the pain to the guy? Because it's going to work. This tear is going to get progressive, and the muscle back there is going to get a little more fatty atrophy, and maybe in 5-10 years the rupture is going to progress after the rotator cuff cable, and is going to lose functionality. And then Dr. Krebs is going to operate the guy, but the tendon doesn't have the quality, okay? Has more retraction, okay, and it doesn't have the substantial muscle that is needed to that suture has a good outcome. So I need to protect his jobs, and I need to protect the patient. But fortunately, not all the patients come to our consultation in this manner. Most of them, thank God, are focal ruptures, are articular ruptures, intersubstance ruptures, or small bursal ruptures. And in these cases, I defy you to use this kind of a medical device, because the results are awesome. Okay, so about tendon thickness, this is, as you see, a complete tear, because this is a LPB. Okay, this is supraspinatus and infraspinatus. All the anterior to posterior exertion is lost. Okay, so it's complete, but also on the thickness, no tendon, gone with the wind. So here it's difficult to try to promote some healing, but. And this is a retraction, okay? We will talk a little bit about retraction a little bit later. But in these cases, most of the cases are just like that, because this is a focal articular rupture. You see here, the hypoechogenic area, okay? A loss of integrity on the tissue. I have a lot of fibers over it, okay? The bursal fibers, 50% are preserved. Most of the ruptures are just like this, because if you see here, the fibers, more articular fibers, they don't have this linear insertion of the bursal fibers. They insert almost longitudinal this way. So they are very strong, they can support a lot of tensile loads, not the articular fibers, because articular fibers do this angulation, okay? And this angulation makes them weaker, and they tear more frequently, okay? So these are the most frequent lesions, most frequent partial tears on rotator cuff. And in these tears, now we have a good word to say, okay? And something to do to our patients. So more specifically, this is an image of a focal tear on the articular side, okay? You see here schematic representation. You can see here some irregularities on the bony footprint, okay? The loss of integrity on the tendon, okay? But this is an circumscribed lesion. I have tendon here, I have bone here, so I can improve I can enhance, okay, the proliferation of these structures, especially the tenocyte cells, maybe the collagenous matrix, adding a support, okay, a scaffold, okay, something to enhance all the properties of the structures that they are lacking, because you know the tenocytes have a mitotic rate that is very low, okay, because sometimes they still don't have the nutrition, they don't have a sufficient matrix to promote this kind of differentiation and local stem cells differentiation. So we need to sometimes put some help in there. Okay, so this is what we are talking about. Intersubstance, interstitial delimitative tears. These kind of tears are more degenerative tears that individual 55, 60 years old, always working his whole life, the tendon gets a little bit degenerative over the years. Okay, he's going to lose his ratio of good collagen versus more strict, more rigid collagen, becomes more amorphous. So these small interstitial lesions can occur. Okay, and this is cause pain. This causes pain because you have here a neuronal sprouting of free terminations of the nerves, and they have an increased ability to produce painful apheresis. So the shoulder gets chronically painful, and this is also a problem, and it's also a good candidate for this kind of procedure for tendon compatible hyaluronic acid. Okay, and then but last, the dorsal side ruptures, more traumatic because we need more strength to rupture this to tear this kind of small like this, and we have less than 50% of the thickness that is injured. We can have here a door to improve this without surgery. Okay, but always focus on the patients, focus on all the context, and focus on what he do and what is his desire. Okay. About tendon retraction, this is also important. Dr. Pate, a long time ago, he defined this classification as a very important classification to know if we can do something with the minimum invasive procedures or if it's more than a surgical candidate. Okay, and you can have a grade 1 to grade 3 retraction. If you see here on the schematic view of this lesion, okay, you have here a tear, and the top of the tendon doesn't pass the bony footprint. Okay, so you don't have a lot of retraction, and if you don't have a lot of retraction, you have a lot of fibers that are inserted still on the bony surface. So we need to improve the remaining tendon because this is functional. Okay, it has full active range of motion, and if you can take off his pain, you have a lot of fibers inserted. If you can stimulate in haste some tissue healing and some proliferation, then you can end up with good results and protection of this remaining tendon. Okay, this is a more severe injury. As you can see here, the retraction goes over the bony footprint, and like this one, it's over the humeral head. This is a grade 2, more retraction, more difficult. Okay, less fibers that are inserted. And then you have the grade 3, the retraction goes all the way down to the joint. So in these cases, we don't have nothing to simulate. So we need to be, again, we gotta be serious. You gotta be honest, and this could be an awesome product, but not in all patients. Okay, we need to take this on mind. Okay. Very quickly, who does ultrasound sometimes to differentiate? This is a common pitfall. Okay, the difference between anisotropy and a small focal articular tear. Like I said, these fibers are angulated. The more articular fibers are angulated, so the pattern of reflection of the fibers, it's not always equal. Okay, sometimes it looks darker, echoic. Sometimes it looks this way, hyperechoic. It's not a tear. It's an ultrasound physic. Okay, pattern. It's different when you have this kind of image, hypoechoic, and you change the ultrasound probe, but this image is always the same, very dark. Okay, so this is a real tear. This is a good candidate for STABA. Okay, enough of this. Let's go to the funny stuff. Our experience so far. Okay, we did with the MDT support. We did this study called ultrasound guided injection of STABA and partial focal and articular. Partial focal articular and interstitial tear of rotator cuff. So we selected the patients with partial tears, okay, and those on the bone, the articular and interstitial, okay. This was the population that we selected. Our aim is to assess the clinical outcomes after ultrasound guided subacromial injection of STABA in this kind of rotator cuff tears, okay. We selected 15 patients, okay, and our assessment parameters were pain in the visual numeric scale and the functional a functional shoulder scale, the University of California, Los Angeles shoulder scale at the first week, okay, 3rd, 6th, and 12th month, okay. And he also had a review about the medication that the patients were taking about pain control, okay. This is the image, okay, and you can see here, this is the tendon, okay, this is the ultrasound guided injection in the bursa, all right. So it's very assertive, it's very, it's in on the spot. You can see here. I'm sorry, I think, okay. These are our results, okay? The results are very, I gotta be honest with you, I got surprised, okay? I got surprised because our baseline pain score was 8, and then the 6 weeks, only 3. Okay, and I thought, okay, this good option, but let's think about long term. And in long term, 1 year, 2.3. So you are a clinician, you know about painful shoulder. Sometimes you do some procedures and you put them on rehab, and they are good patients. They are going to do the things that you say that they are going to do. But the pain, it's recurrent, and they stop rehabilitation, and they stop the strengthening exercise, and the pain comes back, and they can sleep. So at 1 year we had this drop, and it was really a very interesting result, and functionally an improvement that is awesome. You can see here on the shoulder scale, okay, the shoulder scale at the top is 35. They were scoring very low on this function, on the function activities, and at 1 year they can maintain this benefit. And you know, the most iatrogenic drugs that we have are the non-steroid anti-inflammatory drugs. You have a lot of gastric problems, renal problems, heart cardiovascular problems with a chronic consumption of non-steroid anti-inflammatory drugs. And this is a problem because on musculoskeletal pain, the other painkillers like opioids, like paracetamol, they don't have the desired effect because it's a very inflammatory pain most of the time. It's not only a wear and tear degenerative process, we have also a very inflammatory issue there. So the anti-inflammatories work well, but we cannot take them anti-inflammatories twice a day, every day of our lives, because the results are going to be catastrophic. So we need to have alternatives. And this study proven, in this specific study proven that was an awesome drop from more than about 53% of the patients were using painkillers for this kind of problem, and 21% were no longer using at the first year of follow-up. And this, I think, this is also a great outcome in this kind of problem. So we thought in this specific study, this kind of tendon compatible hyaluronic acid was an awesome option for rheumatoid tendinopathy with pain reduction, joint function improvement, short and long term, and could be a good choice for us to take on our consultation in this kind of patients. Okay, and now to the technical procedure. As I told you, we did this all under ultrasound guidance. Okay, and this is the kind of procedure that we used on our study. Okay, this is a longitudinal view. You can see here the bone footprint, the spinatus on longitudinal view, the needle. This was a 22 gauge, 4 centimeters needle. Okay, almost on transverse to or parallel to the probe. And this is a quite easy, if you dominate a little bit about this, quite easy injection to do. Okay, and you put it there, and it's very accurate. Because you see, a bursa is a small structure. Sometimes, if it's not pathological, it's under 2 millimeters of thickness. Okay, so it's under 2 millimeters of thickness. Most of the people have it's very deep, more than 2 centimeters. A tridimension, you have to have a tridimensional navigation of the needle, anterior posterior, on the deep, lateral to medial. So to put that on the thing that it's less than 2 millimeters, sometimes it's hard. So I in the shoulder, ultrasound, I think is a better option. Okay, but what about the rest? If we think this can work as a matrix scaffold, if we think this can enhance tissue differentiation, improve collagen ratios, improve and stimulate stem cells. If this can bring the conditions to the tenocyte to have a better division rate, why not think off label and think about the tear in situ, okay? And that's, I will talk a little bit about this later, but you can think about this, especially on the articular tears like this or intersubstance tears, because here it can really act like a fulfiller, a really matrix scaffold, a really extracellular, non-collagenous matrix scaffold, and bring all the good things that the cells need to initiate a regenerative or reparation process. Enhance, like I said, the proliferation and upregulate on collagen synthesis. And now we are not talking only about reducing pain, improving functional outcomes, but we are also talking about trying to improve the tissue, okay? Trying to get the tissue better, try to drop the recurrence of the pain, okay? And we need to go there. We need to go to the spot, we need to go to the problem, okay? We need to enhance the things there, okay, down there. And as you can see here, the injection is you see the hyaluronic acid, it's fulfilling the gap. And this is one case. It's an articular rupture, as you can see here. Okay, you can see the deformation, the irregularity on the bony footprint. Okay, this is the injection on the spot in situ. Okay, of Stava. Okay, and this is the image 2 months after, and this is a very cool image because you can see here changes on tissue, and you know who works with tendinopathy, the tissue most of the time doesn't change. You can do a lot of things. Some things went very well. Some things reduce the pain of my patient, can put them back in the game, put them back on the work, doesn't have pain on the night. It can do simple things like wearing a coat or picking up a coffee cup. But when you do the image, the damage is still there. And this worries me a little bit because I don't know what tomorrow is going to be. That guy is going to pick up his son and oh, my shoulder, like Diego. And then you have a problem, okay? And this image, it was very special to me because I saw a different thing. I saw an hypoechoic image on the spot of the tear, and this could be fibroblastic differentiation. So an early stage of regeneration. We know this, okay, from other procedures or histological observation. So this could be the pathway, okay? And picking up on this is a case report and the evidence of healing of this case. This is a case that I would like to talk to you a little bit more, and then I will finish. Okay, this was a 36-year-old man, regular crossfitter. Okay, a heavy one. Okay, that guy that goes every day to CrossFit, enters on competition. Okay, big guy, strong guy, no history of other personal comorbidities. And he was presenting my consultation with the right shoulder pain. Okay, he had that classic pain, mechanical, inflammatory. This guy doesn't sleep. This guy goes to sleep. Man, I go to sleep on the couch because I cannot sleep with my wife or on the bed because the pain aggravated. Everything he does overhead, it triggers the pain. He cannot do the things he like crossfitting. Okay, has no trauma, no injuries, no previous injuries. This was a big guy, he was a strong guy, but look at the scores on pain, the visual numeric scale, 7 out of 10. And it's a lot, okay? And a very low functional scoring, okay? This is the classic physical exam on these guys, selective range of motion, pain between 90 and 120, scapular dyskinesis, trapezius parasitism, the tests of insufficiency, negative, but the tests of subacromial impingement positive. Okay, and this was his MRI. Okay, now most of you can are thinking, okay, those were your ultrasound images. How can I know these are the ultrasound images of that rupture, that tear? But so this is an MRI that was done by a radiologist, no bias here, okay? And he told him, he writes in his report, this was a bursal site defect rupture. This is a diaper signal here, okay, on the liquid weighted sensitive sequences. We thought that it was a little bit more than bursal because you see here some irregularity on the insertion on the bone, okay? And I think, yes, this is our ultrasound, okay? And you can see here the irregularity, and you can see here the tear, okay? And we did this, we discussed with the patient, okay? We got the informed consent, we had the approval from the ethical committee, okay? And we did an intra situ hyaluronic acid application, okay, on the spot of the lesion. We used the standard lateral approach, the needle, and we didn't do no suprascapular block. We didn't want any bias, okay? Because you know, suprascapular block is a considered option when managing painful shoulder. Many times the reduction pain using long-lasting anesthetics, it's more than the hours that the anesthetics go. Maybe Ropivacaine 12 hours, and then you have patients that they improve 4 months, 6 months. It's about the peripheral sensitization and cortical sensitization, other things. So we wanted to take all of this of the table and only focus on this kind of intervention. So no blocks here, and we just did the intervention, okay? And this was 1 year of follow-up post-procedure MRI. As you can see here, the difference is obvious, and it's an awesome difference. A very rare MRI after some kind of procedure on the tear that size. Gotta tell you that he came to my consultation. He was sent by an orthopedic surgeon. Okay, you can say this had could have a surgical approach ad initio because he was a young guy who was doing heavy loads, but he didn't want to stop. Okay, he wanted to keep training. He didn't want to rehab. He doesn't have the professional life to do a good rehab, so he came to me and you explain. Okay, we have here a shot. I have this product. It's a good product. Okay. But I think the kind of guy you are, the kind of things you do, we need to have to be a little bit more invasive, okay? And we can do this, okay? This is my thought, and he was all about doing this. We got the consent, then we did, and this is the image. And on the report, he was telling that maybe that tear, that big bursal tear, was only intersubstance, like you see here, this little image. We don't think it's intersubstance. I think it's a complete resolution because on the ultrasound, that image, and you know that ultrasound are better for calcific deposits. I think this is dystrophic calcification following a regenerative process. Usually you can see this dystrophic, it's not about tendinopathic calcification, it's different, okay? This is a scarring process. So I think it's a remaining of the scarring of the tendon. So it is not usual to talk about the scarring of a supraspinatus, okay? The regeneration, it's not usual. Usually it's an injury that's going to follow you all over your life. And this is, I think, yes, it's a 2 years follow-up ultrasound, our ultrasound, okay? You can see it here, the LPB, we're going from anterior to posterior, and then you see here, okay? That tear, that irregularity that you saw on the intervention, even the bone has this characteristics, this normal characteristics, okay? And it's the longitudinal, okay? And I'm not going to lie to you, this is the transverse. And you can see here that calcification. That is a scarring of the tendon, okay? All the other tendon, perfect. It's not thickened, it's hyperechoic, fibrillar, top tendon. Okay, so the conclusion on this specific case, and we are only talking about this specific case, we get this injection, okay, was related not only with clinical benefit, but also imagiological resolution, not only ultrasound, but MRI resolution, okay? And this is awesome. He could rapidly return to exercise. This guy sometimes sends me videos of the competition doing those muscle pull-ups and all those crazy things. I don't know the name, pushing heavy loads, super heavy with this. I saw it a couple of months ago because of his knee. It's another issue. But regarding this, the guy he said was game changing because he was struggling with this some years, and he was really good. And he had no adaptation in sport chassis. This is also important. Sometimes these guys can get back to sports, but they are limited. They are not the same guy that they were before. So this is very important. Who likes to do sports? We feel like we are getting old because we're not the same that we were before. So this is a good thing also. So to take home message, just to finish, I'm sorry for the long talking. In our opinion, this could be a feasible and effective treatment option in the management of this frequent pathology. And I'm not kidding when I'm saying this. I'm trying to put this on my hospital to have everyday access to this kind of medical device, because I think this is going to change the way we treat and we think about tendinopathy. The classic approach, ultrasound guided underpost injection, as you can see on that first study, it was a very good, it had very good results, okay, clinical and functional. And I think this is going to be the way, the injection in situ on the tear, directly on the tear, okay, stimulation, proliferating, enhancing, okay. Thank you all. I'm sorry for the long conversation, but I'm always available for some questions and answers, okay.
Thank you very much, Dr. Krebs, Dr. Carvalho. It was really eye-opening, your experience in this subject. Really surprising results. We're going to start opening the Q&A right now. We're going to start here from the audience. Any questions? I have also some questions that came from our Zoom that I would like also to address with the doctors. But first, I'd like to start here with the audience.
Well, I would. Can I?
Yeah,
this?
please. There's a mic in the back. Just hold on, Dr. Shu. Please, you can open the mic. Thanks.
Well, first of all, thank you very much, Dr. Krebs and Dr. Carvalho for the excellent presentation. A few comments here as to start with. That is we all know tendinopathy treatment sometimes is challenging because we have to deal with not only the symptoms, control inflammation, control pain, but also have to worry about as Dr. Carvalho you say this during, for example, for those focal tears or even interstitial tears, we need to think about how to enhance the structure of the tendon. So in the future, the patient not only recover from the injury, but also improve the healing. The healing is first is the quality, second is the speed, because we want to speed up the healing so that patient can go back to the field or competition, professional competition as early as possible. And then is the recurrence, because otherwise it's very, there's a high recurrence rate of tendon injuries. My first question is addressed to Dr. Krebs in terms of injection techniques. We understand injection, for example, or for the ankle probably is easier without imaging control, but for certain injections, for example, the renal or humeral subacromial injection, bursa injection, and sometimes is not that kind of easy. It can be very challenging. There are different versions, different, let's say, conclusions from different reviews. Mostly say imaging control can help correct placement of the needle. That can help to increase the efficacy and safety of the treatment. That is one thing. But on the other hand, there are certain voices say there's no correlation between, at least between the clinical efficacy and the accuracy of the injection. For example, there's I don't remember which year. I put a note there. There's a Cochrane review some years back. They are not supporting imaging guiding for I think it's rotator cuff injections of corticosteroids, because they don't see eventually even those patients who failed the injection, that the needle is out of the bursa, they still got very good clinical results after the treatment. That is I think that is the reason of Cochrane review. Basically, they are based on this argument. But I would comment on this, but that is mainly on corticosteroids, and we all understand the therapeutic effect of corticosteroids in this case probably is more systemic than local. So in terms of hyaluronic acid, for example, maybe there are not sufficient data available here, but this we will see later on. If later on there will be more studies on this specific topic on the accuracy of the injections. A concrete question to Dr. Krebs is, in your opinion, how important you would say is the image guiding, either fluoroscopic or ultrasound or MRI, in terms of tendinopathy injections in your clinical practice?
Well, I believe that if you do infiltration guided by ultrasound is better and more safe too, because you find the precision local where is the disease. But if you do in a shoulder, I believe that you have to use always is better. When you do the infiltration in the ankle and in the elbow, the structures that have a lesion is more superficial, and you can pulp. It's possible to pulp to do a palpation to took the ligament. When I did the infiltration, I have never using anesthetic before. I use just put, because in the space of the principally elbow and ankle, the small space. If you filtrate the anesthetic, I believe that the space less than you can put the viscous supplement like this. That I don't like to infiltrate corticosteroid. I forgot the last time that I infiltrate a ligament or tendinopathy with corticosteroid. I don't remember the last time. But when you do in a shoulder, like Dr. Carvalho demonstrated, I believe that it's better using guided by ultrasound always.
You have a comment?
Yeah, sure.
Thanks. I know that review, but I would like them to do the same review comparing the subacromial non-guided subacromial corticosteroid injection with intramuscular corticosteroid injection. Those patients also get better. So it's quite confusing those conclusions, because it's in fact the corticosteroids. It's a very potent anti-inflammatory drug. Acts very soon on the inflammatory cascade. So I think that is not the question here. The question is that the corticosteroid really works on tendinopathy, but the limited time that you have, it's short. So I think that's not a long-term option, and we need to measure also the non-desirable lateral effects of the corticosteroid injection. Okay, when you don't do ultrasound guidance, because you can put it directly on the tear. And if you do that, maybe in 2 or 3 months, my orthopedic surgeon is going to be very mad at me because the tendon is losing structure. It's the collagenal. It's going to change. The matrix is going to be more and more amorphous matrix, and he's going to try to do the suture, and he cannot do it. The outcome will be a worse outcome. So I think this is a critic that we must do to that review. Where's the safety on doing that without ultrasound guidance, and what's the difference if we make it intramuscular? Because I think if you have a huge shoulder and you do a supracranial, I don't think that's going to be near the person. Most of the times they get on a deltoid, so it's an intramuscular, and the intramuscular on the classic spot also works fine with tendinopathy. And I think the hyaluronic acid is a complete. It's a different game. It's a different game because you don't have this problem of the degenerated tendon. I was feeling more secure on using without ultrasound hyaluronic acid, this kind of compatibility with the tissue, than a corticosteroid. Because if I miss the spot, if I inject directly on the tendon, the effects, long-term effects or the medium-term effects are not going to be that bad. And I have a chance also to improve the tissue locally. So I think that's the difference. I think we need to, and I'm just like you. I don't remember the last time I put a corticosteroid near the tendon.
We have to remind that the process, the inflammation process, is a part of the recovery of the tendon. And sometimes you need to take a inflammatory. Is a normal evolution of the tendinopathy. You have to combine to combat the process specific, the degeneration of the tendon. But the inflammatory is a part of the recovery.
Well, I would say yes. I'm very pleased to hear that you two shared the view that review was based on corticosteroids, which is very different from hyaluronic acid. So that is something maybe the company should take note and special note and remind let's say the customers, the physicians about this when we read or interpret that review.
Any other questions? Yeah, Dr. Pax, please.
Maybe very short one. Knowing that we understand today the hyaluronic acid working as the tissue regeneration and actually the structural building of the new tissue, ligaments and tendons, and we are at the Football Medicine Congress. Do you consider it makes sense to use it as a preventative factor of the future damage or degeneration of the professional football players, for example, because you mentioned Zverev? It happened something because maybe it was not just a question of the bad movement, but rather a slowing, continuous degeneration of the ankle ligaments, Achilles tendons, plantar fascia, etc., etc. And knowing the fact that the sportsmen are overloaded by the physical activities, the degeneration process is going probably faster and more intense. What would be your opinion about this? Which is not as a doping, but rather for the, let's say, the functional improvement of the mobility apparatus?
I believe that similar to the interarticular infiltrate of hyaluronic acid, I believe that the same, not the same, but it's common to use infiltration in the start of the temperature of the entrainments for players, and if you have a continued using of the ligaments, if you have some possibility of instability, articular instability, I believe that's possible to use to prevent. I use it in some patients that I treat. I have used it.
Yeah, I think nowadays the players are under extremely stressful overload of games. You see on football, but you also could see on other kind of sports Most of them don't have vacations on 3, 4, 5 years because they have the Olympics or because they have the European Championship and then they have the World Cup. And some of them are already accumulating lesions and small tears, and sometimes they go to consultation. Oh, it's my medial collateral ligament again, and I had 10 years ago a small tear, and it's kind of symptomatic always, and this has some compromise of the performance of this player. So I agree, selecting the cases, it could be without symptoms, selecting the cases without, but based on the on this personal history, and also on the kind of sports, because there are sports that they are very getting a little bit out of football, because when you think about swimming, they go and go to the pool and do 4 kilometers, 5 kilometers, 6 kilometers, and you think how many adduction, internal rotation those guys are going to do, a movement that marks a very hard impingement here on the tendon. It's always under the coracoacromial ligament, and they get out of the pool and do 3 series of 15 external rotations. So it's not possible to correct the shoulder on a more balanced position to try to minimize the tear or the lesion or the tendinopathy. So we have this kind of situations that could also bring something to the game, because it's not sports. It's not for doesn't have a health aim. It has a performance aim. Okay, and the coach don't want the guys outside of the water at the same time they are in the water. So they have to practice, they have to train, they need to get better. So here maybe you can have a chance to improve a little bit of the tissue, and maybe think about decreasing the rates of tears and lesions of this kind of structures.
We have
some questions.
questions here. There is a question that on certain questions on really commercial part, which is how much cost the product. I think that is really addressing to
I'll answer in a different time.
also differently. Otherwise, somebody is asking, what is the volume in each sport of ATFC, CFL when you inject? What is the volume you would recommend to inject for CFL or for the volume? Yeah, how many milliliters that is?
I like to infiltrate all the syringe, like put all syringe.
It depends on the size of the tear, okay? Because I'm going to talk only about the rotator cuff tears, because it's a partial tear, it's a focal tear, okay? So you want to put a volume to occupy the space, fulfill the space, okay, to create that scaffold, but you don't want to put a lot of an excess of volume to create tension on the fibers, okay? So I usually put the volume until I don't have any resistance. When I start having resistance on the syringe, and I stop, and my procedure is done, you can put the rest on the subacromial bursa, and it's done.
Great. I have some questions in here, and I believe Dr. Carvalho addressed some of this while he was doing his presentation. Experience with tendon calcifications.
Experience?
Yeah, experience, or Dr. Krebs, yeah, if you have.
I have.
Yeah, great.
Do you have time?
Yeah, we do. We have like 8 minutes.
It kind of steps out of this kind of presentation, but we are now thinking about calcific tendinopathy as a different disease. It has several stages. Okay, it's dynamic. It changes. The characteristics of the calcification, they change over the time. Okay, sometimes they're on the first, second phase, they are more hypoechoic on ultrasound, and you can see also on the X-ray they're very regular, they have a transparency that is similar to the bone, okay? That's a non-touch lesion, okay, because it's stable, it doesn't produce the symptoms. But when you have an outburst of pain and you wake up at night and you go to emergency and you get the painkillers, intravenous painkillers, and nothing passes this, and then you are on the third phase of the calcific tendinitis, and it's the reabsorptive phase. It's kind of like an auto-inflammatory process to that calcification, okay, and it's starting to destruct the calcification. It gets more soft, okay, and if you do X-ray, it's a huge calcification already, okay. You do an ultrasound, it's a big calcification with no shadowing, okay. And in these times I do barbotage and lavage of the calcification. So it's a minimal invasive procedure. We inject under ultrasound guidance saline, hot saline inside the calcification, generates a positive pressure, and then it pulls back the calcium into the syringe. You do 5-10 syringes until the liquid starts to come out white and not that milky. So you have to select. You have to be selective. You have to understand the pathology and when to use the procedure.
I did the infiltration in my brother with infrapatellar tendinopathy in the posterior space of the tendon with a little calcification. He said he did another MRI. I think that 6 months after and disappeared.
Wow.
Disappeared, but it was a little calcification.
Okay.
There are questions online. In fact, that is also my question as well. We understand that looking at Dr. Carvalho, your results is absolutely outstanding. It's really the improvement of the healing is really impressive. In terms of treatment, module treatment versus multi-modular treatment, what is your let's say opinion or clinic in your practice that you combine
other treatment
options together with, for example, steroid injections? For example, somebody asked, do you give corticosteroids? Probably you don't, together with HA at the same time. That is one question. Then I have another one is post-treatment program. For example, do you systemically, automatically prescribe rehabilitation program to the patients after your injection?
Okay, these are good questions. The first question, the question about association with corticosteroid with hyaluronic acid, I think Dr. Krebs already talked about it. Any regenerative process starts with inflammation. So we have the activation of the cells, new vascularization. Nowadays, I don't know, but if get from sports comes to my consultation after an ankle sprain, if it's not that edema, not the ecchymosis, if that doesn't have red flags by saying I don't give ice, I don't give anti-inflammatory, I give paracetamol because I don't want to limitate the first response that could also limitate a better proliferation stage. Okay, so you need things start from the bottom, okay, and then you construct over it. So the answer to that, I cannot think about giving corticosteroids and hyaluronic acid at the same time as unattended, because if I want to maybe produce a new lesion or new process, it always starts with inflammation and then it passes to proliferation. Hyaluronic acid is a means to an end, okay? It's going to facilitate, bring more things to the biological process that exists, but it's failing, okay? So putting corticoid, I think it's not a good option because it's going to drop this response on the beginning, okay? So I think my answer is that. About multimodal and the prescription of exercise and rehabilitation, I'm a physiatrist. I cannot run from that, and I don't agree with the unimodal approaches. because most of the time the shoulder of these guys is already changed, the dynamics, the scapula dysgenesis, they bring the shoulder up and bring the shoulder over. And when I say that sometimes you cannot control symptoms and you cannot control functionality and hope that the structure sometimes gets better or not, and I could have a recurrence. I also think on the other hand, okay, I cannot think about improving the structure and not improving the function and how it moves, how our neuromotor process is programmed, because that injury, if it's an overuse injury, why did it happen? What was the problem? And if it's a bad position of the shoulder, it's not a traumatic one, because if it's something that I do every day, if I am on the laptop every day, just like this, okay, I'm changing the shoulder anatomy to a more impingement position. So I can do an awesome thing with the structure. I can have a perfect MRI, but if that guy still stays the same, still does the same thing every day, and I don't change this, I don't give the shoulder blade stability, I don't pull them against the thoracic. If I don't change the movement pattern, and I only do this with clinical exercise, I got to be direct without good rehabilitation. And when I talk about rehabilitation, I'm not talking about physical agents, not ultrasound or electrotherapy. I'm talking about putting the things back together: mobility, strength, coordination, proprioception, mechanoreception. All this got to be worked, and this is the real physical therapy. Okay, this clinical exercise. It should be called like this. And if I don't put the things back on the spot, back on the anatomic spot, sooner or later, that tear, that injury is going to happen again. Maybe it's not happening on the same side, but not an articular, but on the infraspinatus, I don't know. But we need to correct everything. We are I think our body is awesome. What we do every day, it's damaging our body, our positions, our work. We work 12 hours, 13 hours, sits here, or the sports, the performance. Our anatomy is not prepared for that. So we got to bring the most things together to change this paradigm. I think that's my opinion. Multimodal always.
I believe that if you did an infiltration, it's important to do the best recovery of the shoulder lesion. If you mobilize, this is one information that you have to do. When you have an ankle sprain, you can use in the first 2-3 weeks mobilization, like a air cast. But you start to mobilize with a physiotherapy. That's good, because you have the best recovery of the lesion.
You have mechanoreceptors on the ligaments that respond well to a little bit of stretching. So you have to do early mobilization, a little bit of stretch, eccentric loading, small but and progression. All of these things combined, we're going to improve our outcomes.
Well, great. Thank you again. We wish to address all the questions, but it's just a matter of time too. Thank you to doctors, to all the participants, everyone for helping us on this workshop. It's been great. Again, from MDT side, from all the team, it's a pleasure just to be here. We hopefully see you next year with more cases, with more developments using our technology. And I really gotta appreciate all the effort that Isokinetic did to helping us to put this beautiful workshop and the Zoom link on, so we could all participate from different parts of the world. Thank you again, and just a round of applause for everyone.